So the original name of the project was EHDEN, European Health Data Network, but we changed the acronym to EHDEN, European Health Data and Evidence Network. Well, first of all, it sounds better. It's like Eden being the paradise of data, but it's also very important for us, that second E, because we believe that the project itself is not a success if we map a lot of data to the open common data model. It's just the start of the whole process. The real goal of the project is to create evidence for patient care and make sure that that evidence ends up at the patient in a quick way. So that E is really crucial for us. And I'm very happy that I was able to bring together a lot of nice groups, nice institutes in this project. And like any IMI project, a project consists of a group from pharmaceutical industry. So 11 pharmaceutical companies are involved in the EHDEN project, and it's led by Janssen, by Nigel Hughes. On the academic side, it's Erasmus Medical Center who is leading the project, and I'm the project coordinator. But other universities are involved as well, like Oxford University, Aveiro, and Tartu. But also Uppsala Monitoring Center, very familiar to you all probably, and NICE, which is an HTA body from UK, also a very important stakeholder for what we're building here together. Next to that, we have small to medium enterprises like the Hive and Odysseus, familiar to you all, I think. They are very active in the OHDSI community, have been building analytical tools, doing ETLs, or maintaining the vocabularies, like Odysseus is doing a great job on. And these are very important for us to build the infrastructure, to build the ETL tools, and to extend all the ETL tools that have been already developed in the OHDSI community. Next to that, we have Synapse, which is supporting a project management, and we have non-for-profit organizations like the European Patient Forum, which is also crucial in a large project like this, that we have the patient voice there. And they are an overarching institute that covers all the national patient fora. And ICHOM. And ICHOM is all about outcome standards, familiar to you probably. And we're also looking at applying outcome standards on top of the OHDCDM together with ICHOM. It is a large project in IMI, the Innovative Medicines Initiative type of projects. It's 28 million euro, a large one. And out of the 28 million, we have a very unique, large financial support, a fund of 70 million euro available to map data to the open common data model in Europe. So where is EHDEN about? It's about harmonization, standardizing data to the OHDCDM. In the original call, it was mentioned that we had to map 100 million European patient records to the open common data model. I must say that's not a goal, not a life achievement for me at all. I think it's about having a very nice geographic spread in Europe, especially Eastern Europe. We don't have much data there that we can use, but we also need diversity, so different types of data sources, inpatient, outpatient, etc. The 100 million is something I think we can very easily get to. The other important component is federation. So how do we build the infrastructure using tools built in the OHDSI community like Arachne? How do we implement that on multiple sites in Europe? But that's not the only problem. It's also a social technical problem that we have to make sure that we are in line with the governance procedures, that we know how to set up all these different network studies with all the different people and institutes involved. So it's really a challenge as well to make that a sustainable thing for the future. That cannot be done without a very strong community, so we're investing in that, and I'm very happy also that in these projects, the IMI project, you have multiple stakeholders involved, and that's really needed to make a project like this a big success. Also from advisory boards like the European Medicines Agency and other regulators are involved in our advisory board to make sure that we build something that has high quality, but also answers their questions. And we need to make sure that we build something that's sustainable for the future, and that is really a big challenge. We need many people to make that happen. And that is one of the big reasons why education and training is very high on our agenda. Because I know that we've been building in OHDSI awesome tools, a lot of nice methods, procedures, everything is there. But we need to expand to an even larger community than the people that are in this room. And it's simply not possible for the core team to travel everywhere and to give tutorials. So Patrick and I and others, we have been traveling all over the globe by now, doing these tutorials. And it's fantastic to see the response. But we need to build something that's scalable and something that we can use everywhere. And if I get new PhD students in my group, I can tell them, here's the book of OHDSI, read the book, start with that. Then go into our academy and start training, doing online training. I don't have to explain you the basics of the vocabulary or the CDM. Go there and start there, and then we take it from that point onward. Not only that, but also the regulators, all our stakeholders need education and training. There's still a lot of misunderstanding about the CDM. I hear it everywhere that I go. People don't understand the really important parts of it. We need to have ways to make that much more clear to everyone, and we are investing in that. And finally, it's all about the patient. And outcomes-driven healthcare, learning healthcare system is at the core of EHDEN. So we have a lot of use cases that are focused on, for example, drug utilization studies, factor summation studies, answering important questions within the project with all our stakeholders. And that really drives the development of the infrastructure and the whole project. What's really unique, as I mentioned earlier, is that we have that fund. So we have the 70 million euro that we can use for databases in Europe. We can give it to databases in Europe. So we've spent a lot of time in the beginning, in the starting phase of the project, to build procedures and a whole approach to get data partners on board, to get small to medium enterprises on board for training. So we built a procedure with an evaluation board and a lot of work, an application portal. So these data partners can go to our website, they can sign up for a call, get financial support, and then can work together with certified small to medium enterprises that we are training in Europe to build up that support network that's really, really needed to make it sustainable. It should be its own market at the end of the project. So these SMEs are being trained and they can be linked up with the data partners to help them do their mapping and make sure that this is done at a high quality that we all aim for. So the EHDEN Academy is at the core of training these SMEs at the moment, and we had a demo in the back if you want to have a look later during the break at the end, or at the end of the meeting. What it contains is a lot of nice courses on different aspects. For example, things like the OMOPOM data model, the vocabularies, etc. And we started a pilot now with 80 users, and those are all coming from the small to medium enterprises that we are training and certifying. So just to go through the process and see how we can learn, how we can optimize the curriculum, etc. It currently contains the following courses, so more foundational course on IMI and EHDEN and OHDSI, but also about OHDSI in the box, which some of you may know, but many also don't know. It's a very nice virtual machine that has been set up together with Amazon Web Services, where you can install all the OHDSI tools in your account and play with it and learn from it. And we use the OHDSI in the box functionality in our courses. So when we do these CDM course, there are questions that you can run inside of the OHDSI in the box. And for example, you have quizzes and an exam, etc., etc. What's also very nice, besides the ETL course, which is awesome, also the analytical infrastructure one, I think it's a very important one. I have struggled in the beginning of my experience with OMOP in installing all the tools, and I would have loved to have something like this where I could learn from and have somebody show me how to install Atlas, how to install Web API, etc. And this is an empty virtual machine that you can work on to set up the whole system, and I think it's very, very powerful. We use this now for the SMEs to train them online training with interaction through fora, etc. But there's also a certification phase where these SMEs get certified during a visit, 2-day visit at Erasmus, where we do some training, but also have an exercise where they really have to map a data set to the OMO Common Data Model. What's really awesome, and I was very, very happy with that, is that we got 28 SMEs from 17 different countries in Europe to apply for this. And we did not do a lot of advertisement at this moment because it's a pilot. But the fact that there's so much interest in OHDSI is really, really fantastic. And currently we are training 11 of these companies on all these courses, and 5 of them will do their certification by the end of the month. The data partner call, that's the other call, just finished yesterday, and it was very exciting for me to look how many people actually applied and how much interest there is also from data partner side. And there were 3 ways or 3 options, activities that these data partners could sign up for. One is a complete mapping, so they don't have anything in the CDM, they want to get their full data mapped. The other option is they already have data, because there are data partners in Europe that have mapped their data already and may want to add domains or maybe vocabularies. And the final option is an inspection. So suppose you already have your data completely mapped, an external partner can come in and check your ETL, see whether the documentation is correct and whether the tools are installed correctly as well. In EHDEN, all European countries, all the member states can apply for funding, and also H2020 countries. And you can see our website who actually is eligible here. What was fantastic was that there were 50 data partners that approached us, that they were very interested in mapping their data. Some of them mentioned that they want to apply for the next round because we will have multiple rounds per year. But they were data sources from 14 different European countries. And 28 of them applied, filled in the application form. And what's very nice, they also some of them run Rijnbeek on their data in the application process. So we asked them the question, this is a tool Rijnbeek, can you run it on your data? If not, why can you not run it on the data so we can learn from it? And why, maybe you can run it, but you cannot share it. It's also interesting to know why you cannot upload it. So we learned from that experience. And there were many actually that uploaded Rijnbeek, and we used Rijnbeek to assess the complexity of the data source, and that may drive also the financial support that we will give. Many different types of databases, big databases, databases with 66 million people, but also smaller databases, inpatient, outpatient. And looking at the current form, it's already more than 125 million patient records. And I'm not counting some of the data partners that applied for the same database here. Which is amazing. That's only the first run. Imagine if we can do a couple of those during the project for 5 years. How much European data can we get into the network, and also, of course, in the OHDSI network? I just want to end, before I hand over to Dani to talk about the Oxford Study-A-Thon, with explaining to you that we do much more than that in building that evidence workflow. So we work on the data quality tool, and Claire did an awesome presentation there, and she's also heavily involved also in the EHDEN project. We're building a portal to bring together all the tools under one roof. And another, for me, very exciting thing is the database catalog, making sure that we understand which databases are actually mapped to the OMO Common Data Model, and build some visualizations for them as well. And there is a post on the forum currently where you can get a lot of detail, and also watch a video that Patrick recorded on visualizations across the network. And just to give you a little bit of an idea, we have a lot of nice visualizations showing, for example, the domains for the different data sources, the growth of the network on multiple data sources over time. And I know it's a little bit small, but that's for a reason, because you have to go to the forum, look at it, watch the video, and give back feedback, because we need this to make it a community effort, because we want to open it to everyone. It's not only within EHDEN, it should be on OHDSI level. We also work together with the European Medicines Agency and working with the Article 57 database. That's a database that contains all the medicinal products in Europe, making sure that we can map that to the RX norm or RX norm extensions. It's a very valuable exercise. Build tools for comparison of different vocabulary versions. We do a lot of methods research as well, heterogeneity of treatment effect, a poster also in the back. And finally, the query library. I just want to give it a little bit of attention. because it's not easy to query the CDM. You need to know the vocabularies very well. And I would have loved to have a tool like that 2 years ago, where I could go to and say, if I want to have all the children of a code, what query do I have to run? And it takes some time to think all these things through. And if you have some resource like this, you can go there, you can see all the different queries that people have approved and are using, and you can reuse it also for your own work. And I want to hand over now to Dani, because as I mentioned earlier, community building is very important. And the best way, in my experience, to show the power of OHDSI is doing a study-a-thon. Bringing people together in a small room, have them a couple of days there, and answer a very important clinical question using all the nice tools that we have. And I'd like to invite Dani to give a presentation on that experience in Oxford. Thank you.
It's always, you always have to do this when you talk about after Peter. Okay, I'm delighted to be here in my first US OHDSI symposium. I'm a bit jet-lagged, but I've really enjoyed the meeting so far, and I've seen some epic research. I'm going to be telling you a little bit of a story that's based on true events that happened in Oxford last December, and it's the story of a conversion of myself and some 35 colleagues to the OMOP common data model and to the OHDSI ways of doing things. Our journey started, as always, with a relevant clinical question. We wanted to compare two types of knee replacement that can be offered to patients with severe knee pain due to osteoarthritis. This is, as you can see here, a total knee replacement where the surgeon would change the whole of the joint. And this is a partial knee replacement where the surgeons only change the affected part of the knee. We, of course, then used data that had been previously standardized to the OMOP common data model, and thanks to the generosity of IQVIA and the colleagues from Janssen, we had access to a lot of data, as you will see in a minute. We used the OHDSI tools, and then we hopefully, as you will see, provided some reliable evidence. So what we needed in the room was the people who knew something about knee osteoarthritis, knee surgery, some clinical knowledge on the question we wanted to answer. We needed people who knew something about the data we were going to use, and we needed people who knew how to design studies and how to conduct studies using the OHDSI tools. In summary, the expertise required was we needed people with clinical knowledge of knee osteoarthritis or knee surgery. We needed people who knew something about UK primary care records and US claims data. We needed someone who knew about OHDSI tools, about R programming, people who were able to review the literature and to write up papers. And it will be no surprise to you that nobody could really fulfill all those requirements. So the study-a-thon started the week or a couple of weeks before the actual thing happened, when we posted in a forum and asked people to choose from a number of research questions, and this was the research question that was chosen. So we wanted to learn on the risks and benefits of two types of knee replacement. One is, as I mentioned, partial knee replacement, or unicompartmental here, compared to total knee replacement. This is a question that had been answered previously using a number of different study designs and a number of different approaches, mostly in observational data sets. There had been a total of 20 years of data and more than 60 studies, 60 that have been deemed to be of good quality. And interestingly enough, this April 2019, so about 4 months after we finished, there was a systematic review published in the BMJ. I'm not going to bore you with the detail. You can look it up. It's all open access. But what the authors of that systematic review found was that partial knee replacement was associated with a reduced risk of postoperative venous thromboembolism, so that would be blood clots, which is a typical complication from any lower limb surgery, potentially or possibly a reduction in postoperative mortality, although there was very little data on this available. There was a lot of data on knee pain, knee function, and patient-reported outcomes, most of that data pointing towards a beneficial effect of partial knee replacement above and beyond total knee replacement, but also an increased risk of revision surgery. This is where the surgeon has to go back into your knee and either retrieve or replace the kind of metal work that they've put in. And if you could see this, the effect size is about a 70% pooled estimate, has a ratio of 1.70. Unfortunately, there are some caveats about the quality of those 60 studies and 20 years of data, and probably due to that, there were 2 ongoing NIHR UK-funded studies looking into this research question. A surgical randomized controlled trial where people were randomized to receive one or the other type of surgery that was called TOPCAT, and that has now been reported in full in a Lancet paper, as you can see there. And then there was a research study conducted by my group in Oxford looking at different methods to try and replicate that trial. This was called ATMOST. When I was considering joining this journey, I of course, was trying to prioritize what was important in the coming few years for my group. And when I have to do that, I usually go and look to some of my my mentors. And Doug Allman here is one of, I think it's been mentioned previously today already a couple of times, was a brilliant statistician that set up the Center for Statistics in Medicine in Oxford. And he wrote, I don't know, thousands of papers, but this is one paper that I really like called The Scandal of Poor Medical Research. And Doug in there mentions, I think it's the first sentence of the paper probably, he says, we need less research, better research, and research done for the right reasons. And I thought that probably trying to show that in a week we could do what people had been doing for the last 20 years, and in one paper we could do what people had done in 60 papers was really worth a try based on that. So our aims, we wanted to see if we could predict the results from the TOPCAT ongoing randomized controlled trial that was still not reported, and we didn't know the findings for at that stage. And of course, we also wanted to learn on things that the trial would not be able to look at, including safety issues. This was the plan for the week. We started on Monday basically refining the research question and drafting cohort definitions. On Tuesday, we looked at the characteristics of those cohorts and we started designing a patient-level prediction study. On Wednesday, we had already some results for the prediction study that I will show you in a minute, and we started looking at external validation of the prediction models. On Thursday, we started looking at population-level estimation, and then we reviewed the diagnostics from that analysis. And on Friday, we reviewed the final results, and very importantly, I think, we allocated very specific tasks to people so that we made sure that we had 3 abstracts submitted by the end of the week and 2 papers submitted in the following weeks. We refined the research question. We put it in more of a kind of OHDSI, if you like, terminology, as you can see here. That happened already on the first day. We opened a Google Docs where people could take notes during the meeting, and everybody was contributing to that during both the kind of breakout groups and exercises and during the sessions. We opened already 2 Google Docs as well, one for the patient-level prediction paper and the other one for the population-level estimation. And then we started playing and learning Atlas. So many of the colleagues in the room, I think most of them had never used Atlas before, and we used the public version of Atlas as well as a private version of Atlas from IQVIA, where we could access real-time thin data, which is primary care electronic medical records from the UK. So what did we learn already by Friday? You can find all the results in these 2 websites. We will, of course, upload these slides later, so you can play with that if you want. But in summary, what you see is that we had data from 5 different data sources, 4 from the US and 1 from the UK, as I mentioned. And if you compare the results from the previous 20 years of research on VT, they had about a 50% non-significant reduction in risk of venous thromboembolism post-surgery, and we had an about 40% reduction in risk, significant in our case, in just a week of work. And if you look at long-term revision, this was the other thing that had been looked at for the last 20 years. They obtained a risk ratio, pooled risk ratio of 1.70 in the systematic review, and we had hazard ratios that went from 1.5 to 2.2. Now, compared to the 3 million trial that was ongoing, the TOPCAT trial found a small improvement in pain and function with partial knee replacement compared to total knee replacement, and we found a similar small reduction in the use of opioids, which was our kind of surrogate for that variable. TopCat was not powered to look at safety issues, so we couldn't see if we could replicate that. But revision, interestingly, was not found to be increased in partial knee replacement compared to total knee replacement in the TopCat trial, which was kind of worrying when I saw this only after we submitted our paper. And actually, if you read the full Lancet paper on the TopCat trial, what you will see is that the authors basically mentioned that all the previous studies, the previous 20 years of research was all flawed because there was a lot of confounding, and that's why they were finding an increased risk of revision. So I guess this is a similar scenario to what we were discussing this morning of comparing a trial to a lot of observational research. Maybe the previous observational research had not been done appropriately, but our research, as I showed, found also an increased risk of revision. And we were in this conundrum where I was wondering, have I wasted not only this whole week, but my whole career probably by doing this kind of research? Now, interestingly, as I mentioned, we had this ongoing ATMOS trial where we had a little bit more granularity. We had access to the National Joint Registry from the UK, and in there, we analyzed the data using a number of different approaches. The first thing to see here is that the TopCat trial results indeed don't show an increased risk of revision risk, but the confidence interval is kind of wild in there. What we found in our data from the UK was very similar to what I've shown earlier, a kind of double risk of revision risk using different propensity score methods, and I'm not going to go into the detail. And then what we found that I think you'll find interesting is that there was a very strong learning curve and a very strong impact of a learning curve here, where you see that surgeons that have very little experience doing partial knee replacements had a very high risk of revision, while surgeons that had more experience with it had a revision risk very similar to surgeons that did total knee replacement. So here in this example, surgeons' experience is an effect modifier, and if you then go back to the ATMOS data from the National Joint Registry and start restricting the analysis to the surgeons with more experience, you can very easily replicate the trial by getting a hazard ratio that gets closer and closer to the null as they did. And I guess the question you have to wonder yourself here is whether you really want to know what the true effect of partial knee replacement is when you put that in the hands of a very experienced group of surgeons in a kind of lab setting as the one you use for a trial, or whether you want to know what's going to happen if you go out there and get your knee replaced by the first surgeon in the NHS. We also had another set of results that have been presented very nicely by Ross, one of Peter's students, in one of the posters about prediction. I'm not going to go too much into detail because I think we are a little bit out of time. But we basically looked at a different set of outcomes, and we found that we could predict post-operative mortality. And, this is the model. This is the plot where you can see the characteristics according to outcome status. And as you can see here, we had a very nice area under the ROC curve and very nice calibration. And we also had data from external validation studies. Outputs, in that week we managed to submit 4 abstracts, and that has resulted in a podium presentation at the biggest osteoarthritis conference in the world called IOF-SEO with more than 3,000 researchers that was presented in April. Another podium presentation with a press release at EULAR, which is the biggest rheumatology conference in the world with more than 15,000 rheumatologists. And interestingly here, I was in the room, I had to leave the room for a physiological reason, and when I came back, it was completely full, and I had to stay out of the room to see the presentation from one of my students, which was quite an interesting experience. And then when it comes to manuscripts, we have a paper that has been approved with major changes at Lancet Rheumatology, and we've just submitted the revised version, and we have a paper submitted to JAMA Surgery. Now to conclude, what did I learn myself also by Friday? Well, the first thing that I learned is that it had taken us a little bit too long to join this journey. The Oxford kind of central buildings were set up in the 15th century, so that's about 500, 600 years that's taken us to get there. And if I wonder why did this take so long, I guess there's a combination of tradition. We like to do things in a certain way in Oxford, and we have credit for that, and a little bit of laziness. Or maybe, although some people claim that we are the best university in the world, we are not as good as we think. And we, although being very good, we still train people like this guy here who's going to take us over the rink in the coming few weeks. But indeed, it's hard. I mean, for the people in the audience who have not been in Odyssey before, it's hard to start a journey. It's hard to join a journey. You can see, if you could zoom in these people's faces, you would see how Patrick is making a real effort here to keep the boat stable for the other two to jump in. But once you find a safe and a good boat, I think it's all about the journey and having a long one and enjoying it. And as the poem says here, having a lot of adventure and discovery. I'll end with that. Thank you.